This video presentation is on theory question paper discussion. Here, one long essay, 5 reasoning question, 2 case-based question, and 9 direct will be discussed. Now, this is a long essay which states that a 32-year-old male manual labor presents to outpatient department with complaints of fatigue, joint pain, bleeding gums, and poor wound healing for past 2 months. He gives a history of consuming mainly rice-based meals with very light intake of fruits and vegetables due to financial constraints. On examination, swollen and bleeding gums, petechial hemorrhages, and loosely attached teeth are noted. So, what's the likely vitamin deficiency in this patient? So, this is due to deficiency of vitamin C. Name the disease caused by this deficiency, which carries 1 mark. The disease is scurvy. Explain the biochemical role of this vitamin in collagen synthesis for 2 marks. What you need to write is collagen is made up of 3 amino acids: glycine, proline, and lysine. Now, of this, proline and lysine undergo post-translational hydroxylation catalyzed by hydroxylase enzyme, prolyl hydroxylase and lysyl hydroxylase respectively. And this enzyme requires vitamin C as coenzyme to form hydroxyproline and hydroxylysine. And these two compounds help in formation of cross-linking, which increases the tensile strength of the collagen. So the next question is explain the other biochemical function of this vitamin for 3 marks. So these include reduction of ferric to ferrous form, conversion of methemoglobin to hemoglobin so that it gets back the oxygen carrying capacity, conversion of tryptophan to 5-hydroxytryptophan, which is serotonin, synthesis of serotonin, which acts as neurotransmitter in central nervous system, conversion of tyrosine to para-hydroxyphenylpyruvic acid and subsequently to homogenesic acid. This requires vitamin C. Conversion of folic acid to its active form tetrahydrofolic acid requires vitamin C. Phagocytosis by leukocytes or the WBC also requires vitamin C. Vitamin C acts as hydrophilic antioxidants and it also decreases the cataract formation. So these are the other functions of vitamin C, which is for 3 marks. List any 4 dietary sources rich in this in which vitamin C is rich. So these include the amla being the richest source, followed by guava, orange, lime, and lemon. So state the recommended daily allowance of this vitamin for adults. It is around 75 milligram per day. This is how you need to present the answer for. Now coming to reasoning based question, phospholipase A2 has been implicated in snake venom toxicity. So this is asked for 3 marks. Now you need to write the structure of phosphatidyl lecithin, that is phosphatidylcholine, that is lecithin. Now the 3 carbon atoms of the glycerol, they are attached to fatty acid. So we have a saturated fatty acid at C1, unsaturated fatty acid at C2, and at C3 phosphorus group and the base nitrogenous base choline is there. So when phospholipase act here, so the remaining compound that is released is known as lysolecithin, and this lysolecithin is present in the venom of the viper. So this lysolecithin is a hemolytic agent. It causes massive hemolysis resulting in renal failure and subsequent death of the patient if not treated. Instead get converted to lactic acid. The other important reason is the metabolism of alcohol, where ethanol gets converted to acetaldehyde, subsequently it gets oxidized to acetic acid. Now this is a redox reaction where ethanol is getting oxidized, simultaneously NAD is getting reduced to NADH. When there is abundant presence of NADH inside the body, this facilitates reduction of pyruvate to lactate. Hence lactic acidosis is common among alcoholics. The next reasoning based question is sucrose is non-reducing. Why is it so? This is because sucrose is made up of glucose and fructose, and the linkage is 1,2 linkage, which involves the first carbon atom of glucose and the second carbon atom of fructose. Now this linkage abolishes the functional group of aldehyde which is present in glucose and the keto group which is present in fructose. And as we all know that the function group is very much needed to reduce the Benedict's reagent, and this function group is involved in glycosidic linkage and is not available, hence sucrose is non. The next reasoning based question is polyunsaturated fatty acids are more known for rancidity. This is because PUFA contain unsaturated fatty acids, which is nothing but the presence of double bonds, and these double bonds are prone for free radical attacks, and this results in the formation of epoxides, peroxides, contributing to development of rancidity. The next reasoning based question asked for that can be asked for 3 marker is INH therapy. Isoniazid therapy leads to PLP deficiency or B6 deficiency. This is because INH forms inactive complex with PLP. The second reason is it inhibits pyridoxal kinase and reduces the formation of active form, that is pyridoxal phosphate. And the third reason is it increases the urinary excretion of PLP. Now, case-based 5-marker question. The case is as follows. A 43-year-old strict vegetarian female complains of progressive fatigue, tingling sensation, both feet, difficulty walking. Examination reveals smooth, beefy tongue, pallor and hyperreflexia. CBC, that is complete blood count, shows megaloblastic anemia and peripheral smear shows hypersegmented neutrophils. So the 3 different sub-questions have been asked. The first question is explain the biochemical role of vitamin B12 in nerve conduction. Now we all know methyl tetrahydrofolate is getting converted to tetrahydrofolate, and this requires cobalamin, and cobalamin, after accepting the methyl group from tetrahydrofolate, it becomes methyl cobalamin, so that the active form of folic acid, that is tetrahydrofolic acid, is generated. So in the subsequent step, methyl group is donated to homocysteine and homocysteine get converted to methionine. So methionine acts as a methyl group donor. It donates a methyl group to phosphatidyl ethanolamine, and this phosphatidyl gets converted to phosphatidylcholine, which is one of the component of myelin sheath. So in vitamin B12 deficiency, what happens? There is decreased formation of myelin sheath and there occurs demyelination at different areas in the central nervous system, resulting into the development of neurological problem. Now this demyelination affects both cerebral cortex and the spinal cord, that is in particular dorsal column and the pyramidal tract. So that's the reason why subacute combined degeneration contributing to neurological problem is common in B12 deficiency. Next question asked was how to differentiate B12 deficiency from folic acid both clinically and biochemically. So clinically B12 deficiency is characterized by neurological manifestation, and these manifestations are not present in folic acid deficiency. And the neurological manifestation include symmetrical paresthesia of extremities. So the problem involves both the extremities and it is symmetrical in nature. Altered tendon reflexes, loss of position sense, the gait is unsteady, Romberg sign is positive. This means the patient falls with his or her closed eyes. Next is Babinski's sign positive, where the plantar reflex is extensor. The lab findings include, so there occurs methylmalonic aciduria. This actually can be seen in both B12 and folic acid. Why there is methylmalonic aciduria? This is because the metabolism of short chain fatty acids end up with formation of propanol-CoA, which gets converted to D-methylmalonyl-CoA, L-methylmalonyl-CoA, and L-methylmalonyl subsequently gets converted to succinyl-CoA by the enzyme mutase, and this requires B12 as cofactor or the coenzyme. In B12 deficiency, what happens? This methylmalonic acid is not getting converted to succinyl-CoA. This gets accumulated in the blood and gets excreted in urine, contributing to the development of methylmalonic aciduria. Actually, this is seen in both B12 and folic acid also. The main differentiating test is Schilling test, which is positive in B12 deficiency but not in folic acid deficiency. Now, how this Schilling test is performed? So radioactive, that is cobalt labeled B12 is given, both IM and oral. Intramuscularly it is given to saturate the stores, and this oral cobalt labeled B12. So when it is given and after 24 hours the urine excretion of B12 is measured. So normally if the person is not suffering from any B12 deficiency, what happens? Whatever the radio labeled B12 is given, it gets completely excreted in urine. So in deficiency, what happens? Less than 5% of the radio labeled B12 is excreted. Now the question arises whether it is due to B12 or intrinsic factor. So we need to repeat the test of radio labeled B12 along with intrinsic factor. So in pure B12 deficiency, what happens? Completely it is excreted, whereas in and the test is considered as negative. In intrinsic factor deficiency, it is completely it is excreted in intrinsic factor deficiency and the test is considered to be positive. Whereas in B12 deficiency, it is negative because the excretion is less than 5% or there not be any excretion. So this is how we need to differentiate B12 folic acid deficiency. Next case-based question is, the case is as follows. 62-year-old male with a history of chronic alcoholism, presents with loose stool, confusion, dark scaly skin on exposed part of the body. Examination shows glossitis and dermatitis around the neck. What is the likely diagnosis? Diagnosis is pellagra. What is the term given for this characteristic lesion on the neck? It is Casal's necklace. Explain the pathophysiological basis behind the triad in this disorder. So this is a triad of dermatitis, diarrhea and dementia. Dermatitis because there is, now we all know tryptophan is needed for the formation of niacin, and active form of niacin include NAD and NADP. Because the NAD and NADP are decreased, so there is decreased fatty acid synthesis and decreased skin repair, contributing to the development of dermatitis. Next, diarrhea, there is again decreased NAD and NADP, and these are required for the activity of the intestinal epithelial cells. So when these are decreased, this leads to formation of inflammation, mucosal atrophy and diarrhea. And the third part of the triad is dementia, again decreased NAD and NADP, decreased neuronal energy metabolism. So the main problem or the biochemical basis for pellagra triad symptoms include decreased formation of niacin, decreased NAD and NADP. So decreased energy metabolism in skin, contributing to the development of dermatitis. Decreased NAD in intestine, contributing to the development of diarrhea, and decreased NAD and NADP in brain or the central nervous system, contributing to the development of dementia. So the next question is, name the vitamin and its coenzyme form involved. So vitamin is niacin, coenzymes include NAD and NADP. Next, what are the dietary and biochemical causes for this condition? So the dietary deficiency is due to decreased intake. Next, the second cause is decreased synthesis due to decreased availability of PLP, that is B6. This is because tryptophan gets converted to N-formyl kynurenine. This gets converted to kynurenine. Conversion of kynurenine to antranilic acid requires pyridoxal phosphatase coenzyme. So if there is decreased availability of PLP, again niacin deficiency is seen. So the next cause is carcinoid syndrome. Normally 1% of the tryptophan gets converted to serotonin. In carcinoid syndrome, what is happening is 60% of the tryptophan is getting converted to serotonin. So there is decreased formation of niacin. Next cause is Hartnupp's disease. So this disorder is characterized by defective absorption of tryptophan from the intestine. So in all these conditions, niacin deficiency is encountered. Next question, direct question. Discuss the structure, classification and function of phospholipids. Now this is the structure of the phospholipids. You can represent the glycerol 3 carbon atoms. The first carbon atom saturated fatty acid is attached, second carbon atom unsaturated fatty acid is attached, and to the third carbon atom phosphate and the nitrogenous or the non-nitrogenous base is attached depending upon the classification part. So the phospholipids can be classified as nitrogen containing phospholipids, which include phosphatidylcholine, lecithin, which acts as lung surfactant, phosphatidylethanolamin cephalin, which is a component of the biomembrane and acts as mild anticoagulant also, phosphatidylserine, also component of biomembrane. So the next is non-nitrogen containing phospholipids. This include phosphatidylinositol, which acts as second messenger for hormone, phosphatidylglycerol, component of biomembrane, cardiolipin, component of mitochondrial inner membrane. The last part is the plasmalogens, which include choline and ethanol plasmalogen, mainly present in brain and muscle tissue. So the next sub part of the question is, add a note on their amphipathic nature and role in biomembrane. So this phospholipids have got polar and the non-polar part. Polar part is hydrophilic and the non-polar part is hydrophobic. That represents the amphipathic nature of the phospholipids. Now because of this amphipathic nature, phospholipids can form micelles which help in absorption of lipids and also absorption of fat soluble vitamins. The amphipathic nature also contribute to the development of liposomes, which are used in target drug delivery, mainly vaccine delivery to the target tissues and target chemotherapeutic drug delivery to the cancer tissue. The next direct question is, classify proteins with suitable examples. Proteins can be classified based on their function, composition, shape and nutritive value. Based on function, they can be classified as catalytic proteins, example being enzymes, structural protein collagen, contractile protein actin myosin, transport protein albumin, genetic protein histone, protective protein immunoglobulin, regulatory protein hormones. Based on composition, they can be classified as glycoproteins, example blood group antigen, lipoprotein, HDL, LDL, VLDL, IDL, chromoprotein, hemoglobin and rhodopsin, nucleoprotein histone, phosphoprotein casein, vitellin, metalloprotein, ferritin, ceruloplasmin, cytochromes. Based on shape, proteins can be classified as globular, albumin, fibrous protein, example collagen. Nutritive value, proteins can be classified as complete protein which contain all the amino acid, casein of milk, milk egg albumin. Incomplete protein where they lack one amino acid, cereal lack lysine, pulses lack methionine. Poor protein where they lack more than one amino acid, corn of zein lacks both lysine and PAN. So the next direct question is describe mucopolysaccharide with examples, functions. So mucopolysaccharides include hyaluronic acid and they are made up of amino sugar and glucuronic acid. Hyaluronic acid is made up of glucosamine and glucuronic acid mainly present in synovial fluid and vitreous humor. Chondroitin sulfate is also made up of glucuronic acid but the amino sugar is different, galactosamine. So that's mainly present in cartilage and bone. You can remember hyaluronic acid and chondroitin sulfate, they have the common glucuronic acid but the amino sugar differs. Next is heparin and dermatan sulfate. You can remember together because both of them have iodinic acid and again the amino sugar differs. Heparin has got glucosamine and iodinic acid mainly present in skin and lung, whereas dermatan has got galactosamine and iodinic acid present in blood vessels, heart valves and also in skin. Heparin also has got iodinic acid and glucosamine mainly present in mast cells, lung and liver. Keratin sulfate does not have uronic acid. It has got glucosamine and galactose. It contributes to corneal deficiency. Now the other direct question is give reactions involving amino group and the carboxyl group of amino acid. Now you can write the general structure of the amino acid like C with representing H and R, the amino group and the carboxyl group. So reaction due to carboxyl group are mainly of two types, decarboxylation and amide formation. So when an amino acid undergoes decarboxylation, it forms its respective amine. Examples include histidine forms histamine, tyrosine forms tyramine, tryptophan forms tryptamine, and glutamate forms GABA. Amide formation is glutamate combines with amino group and form glutamine. Similarly, aspartate combines with amino group and form aspargine. So reaction due to amino group transamination, where amino acid donates the amino group to keto acid and the keto acid gets converted to new amino acid and the amino acid gets converted to a keto acid. Example is alanine donates amino group to alpha ketoglutarate and alanine gets converted to pyruvate and alpha ketoglutarate gets converted to glutamate. So glutamate is the non-essential amino acid synthesized from alanine. So next is oxidative deamination. Now this transamination is taking place in all parts of the body and oxidative deamination exclusively operates in the hepatocytes or the liver where the amino group where the glutamate reaches the liver and in liver and the hepatocyte glutamate undergoes oxidative deamination to form alpha ketoglutarate and ammonia. Subsequently this ammonia gets detoxified to urea. So this oxidative deamination is taking place in liver and this is mainly because of reaction, and this is one more example for reaction of amino group. The third example is formation of carbamino compound where hemoglobin combines with carbon dioxide to form carbamino globin. Next, direct question. Enumerate the sources of biochemical function of pyridoxal phosphate. Discuss deficiency manifestation and drug-induced B6 deficiency. So the active form of pyridoxine is pyridoxal phosphate. The sources include the whole cereals, legumes, green leafy vegetables. PLP function reactions where PLP acts as coenzyme. The first reaction is transamination where amino acid gets converted to keto acid. Decarboxylation where amino acid gets converted to amine. So transulfuration where homocysteine gets converted to cystathionine. Heme synthesis, the first step of heme where glycine condenses with a succinyl-CoA to form delta aminolevolinic acid requires PLP as coenzyme. Catecholamine synthesis, they are synthesized from tyrosine. Tyrosine gets converted to DOPA. DOPA gets converted to dopamine and this conversion requires PLP. The glycogen breakdown where glycogen is broken down to glucose 1-phosphate which gets converted to glucose 6-phosphate and finally gets converted to glucose. So glycogenolysis also requires PLP. Niacin synthesis, that is from tryptophan, also requires PLP. So deficiency manifestation. So because there is decreased formation of GABA, neurological manifestations are seen. Decreased PLP, pellagra, decreased niacin, dermatological manifestations are seen characterized by pellagra, and decreased formation of heme, hematological manifestation in the form of anemia is seen in PLP deficiency. Coming to drug-induced B6 deficiency, this is INH isoniazid antitubercular drug. This inhibits PLP dependent enzymes causing neuropathy. Next, the drug is oral contraceptives, increase the metabolism of PLP or B6 and can cause neuropathy. Next one, explain the classification of enzyme and with suitable example. Asked as 5-marker question. So they can be classified as oxidoreductases involved in transfer of hydrogen. Example is oxidation of alcohol to acetaldehyde and subsequently to acetic acid. And the IUB name is alcohol NAD oxidoreductase. Second class include transferases, which transfer group other than hydrogen. Example is conversion of hexose to hexose 6 phosphate, and the phosphate is donated by ATP. The IUB name is ATP hexose 6 phosphate transferase. The third class is hydrolases, which cleave the bond after adding water. Good example is breaking down of acetylcholine to choline and acetate. The IUB name is acetylcholine hydrolase. The next group is lyases. They cleave the bond without adding water. Conversion of malate to fumarate. Example is malate hydrolase. Class 5 isomerases, which bring about intramolecular rearrangement. Example is interconversion of glyceraldehyde 3-phosphate and dihydroxyestone phosphate. The IUB name is glyceraldehyde 3-phosphate isomerase. The last class is ligases, which bring about joining of two molecules with the energy provided by ATP. Here, condensation of acetyl-CoA with carbon dioxide to form malonyl-CoA. IUB name is acetyl-CoA ligase. The next direct question is describe the coenzyme functions and deficiency manifestation of folic acid. Add a note on causes and assessment of folic acid deficiency. Now the coenzyme of folic acid or the active form is tetrahydrofolic acid. Main function of folic acid is transmethylation reaction where mainly conversion of homocysteine to methionine. That is how folic acid participates in 1-carbon metabolism. Now these are the donors of the 1-carbon compounds. The first donor is tryptophan, which forms the formyl tetrahydrofolic acid, and the acceptor is C2 of purine ring. So the next donor is histidine, which forms methynyl tetrahydrofolic acid, and the acceptor is C8 of the purine ring. Choline contributes to methylene tetrahydrofolic acid, and this is taken up by serine to form glycine and deoxy-UMP to form deoxy-TMP. Methionine forms methyl tetrahydrofolic acid and is responsible for transmethylation reaction for conversion of norepinephrine to epinephrine, epinephrine to metanephrine, acetyl serotonin to melatonin, guanidinic acid to creatine. So deficiency of folic acid manifests as macrocytic anemia. This is because of delayed DNA synthesis, but protein synthesis continues. And it is also characterized by neural tube defect, spina bifida and fetus due to folate deficiency in pregnant lady. And the other one manifestation is hyperhomocysteinemia. This is because of impaired conversion of homocysteine to methionine. What are the causes for folate deficiency? Inadequate intake, mainly because of poor diet, or chronic alcoholism also contributes to deficiency of folic acid, malnutrition, elderly individuals. So in all this, the inadequate intake is seen. Malabsorption, then increased requirement in pregnancy and lactation are the causes for folic acid deficiency. Assessment of deficiency can be done by estimation of folic acid in blood serum, estimation of homocysteine in plasma, estimation of methylmalonic acid in serum and blood, and the histidine load test or Figlu excretion. So deficiency, what happens? Large amount of formoaminoglutamic acid is excreted in urine. So this is one of the classical test for assessment of folic acid deficiency.